And let's dive into this sort of like theme, which is actually set by you, Heinz, and further philosophized. So before deciding on an open repair or endovascular repair, one needs to consider many things. So the histology, the anatomy, and the clinical presentation, and actually what the patient prefers. This is an entity we should not forget. Yes, endovascular approaches, they have advantages and they have also disadvantages. Open repair as well has advantages and so forth for the disadvantages. My first sort of like a spin to this, I'm going to direct the questions now to you, Stephan. Stephan, you're well known for this. From Lille, from Paris, your name is very much eminent on the French sector, French side. I've scratched the surface reading about you because Heinz suggested your name, and I was amazed by the things that I actually wasn't raised and abroad in Britain on the endovascular side, because in Britain, as a cardiac surgical person, we are all much involved in cutting, opening, and splitting. But now the trend is changing. Stephan, to date, the clinical outcomes have been really promising with the design of endovascular surgery. However, these sort of like, designs and approaches, especially for the arch vessels, have been really hindered by many factors, and they're not pretty much warranted because of the durability and also because of the long-term outcomes. What can you share with us on this, and where do you see the future in this entity? Stephan.
Well, thank you, Mohamad. I think it's a very good point. We have to consider branched arch technology in its infancy. So, I mean, we're really going through the learning curve in patient selection and how to do those procedures. And we've seen from the couple of papers we've been involved in that the very early stages were those stages where you treat patients that are very, very sick, and even rapid pacing is too much for most of those patients. And so we maybe pushed the envelope a bit too far to know a bit more about the technology. And now we're moving with Tilo and others into a more mature approach of this technology. And Joe pointed out that we now actually know which patients are the good candidates for such an option, and probably those patients that had a prior ascending repair following an acute type A dissection. So and coming back to what Heinz just said, we have a very open approach. I have some people consider me an endomaniac, but I've always worked in centers where we do a lot of open surgery. In my department in Lille, we were doing 350 aortic repairs a year, 100 open and 250 endo. So open was still, a big player in my department. And so I think we really need to come up with what I call aortic centers, including cardiac surgeons, vascular surgeons, or any endovascular therapist, and cardiologists and the ICU people. And we have a clear discussion for all those cases. And in my new center in Paris, every Monday evening, we see all those cases together. And there's no conflict because we are all on a salary cap. And if I do one case more or one case less, I don't care. It's just that we're trying to find the best option for each patient. So we believe that now endo is a valid option, and it has to be part of the discussion. But we're not going to push endo if it's in a 35-year-old connective tissue disorder patient. I think open should be the first.
That's a very good point, Stephan, which I'm going to now steer the question to Joe. Joe, you've been instrumental. The name Bavaria is now everywhere you go. Everybody knows you. Everybody knows pen surgery, pen medicine. You've been instrumental in introducing TAVR and TEVAR in the US. Stephan has touched on a point, which is, pushing the boundaries of endovascular into the zone of, or into the arena of patients who do not require them. Can you, from your experience, Joe, identify to us or tell us which patients should we be identifying for endovascular approach? And is that going to change? Are the substrate of patients going to change in the future? Joe.
First of all, it's about disease management. So we've always been disease managers, and And the fact of the matter is, and this is both for valvular heart surgery with TAVI and even transcatheter mitral approaches, as well as aortic surgery, thoracic aortic surgery in particular. So what happens when you're a disease manager in any of these issues is you do what's best for the patient. And a lot of times what's best for the patient is in evolution. And if the endovascular approach is either equal to or better than the open approach, the endovascular approach is always going to be utilized. And so this is the nature of the business. And that's why we don't care which way we do things. We don't even care whether we treat them medically. Why? Because we're disease managers. And the entire approach, and in our place, it's mostly a cardiovascular approach. Cardiology and interventional radiology are really not a part of what we do, but the cardiac surgeons and the vascular surgeons are really in the same arena. So in our approach is really a disease management approach, and it doesn't make any difference whether it's open or endo or even medical management. So now, as far as endovascular thoracic aortic surgery, to be precise, in my opinion, the march towards endovascular is going to continue. It'll continue as endovascular devices and endovascular techniques improve, and it's both of those, techniques and devices. There is a little bit of a natural barrier, so to speak, at the ascending aorta. Because the ascending aorta in its common presentation does not have a landing zone. There is that whole concept is doesn't exist. So we're going to see some problem with the majority of ascending aorta cases and arch cases because of the proximal landing zone issue in the proximal aorta, which really only exists, honestly, at the annulus. So what's happening is arch TEVAR is here. And in fact, it's not in the future. It's here. And why is arch TEVAR here? It's because arch TEVAR is not that difficult in the sense that it's not conceptually a problem. As long as you have an ascending aortic landing zone, arch TEVAR is alive and well. And we design, when we talk about our disease management program, the cardiac surgeons and the vascular surgeon, I hate even saying those words because I like to use the word cardiovascular in our institution anyway. Every single option and operation, therapeutic operation is designed for an eventual downstream TEVAR solution. And so when right now there's not that many ascending aortas capable of taking a stent graft directly without having problems. So, but that's going to come eventually. So I would say that we do index operations at the proximal aorta with the idea that TEVAR is going to be the solution for the aortic arch and the descending aorta at this point. 5 years ago, we did the same thing for the descending aorta. Now we do the same concept for the aortic arch and the descending aorta. There you go.
Okay, that's a good spin. We jumped ahead, but I like it. But I'm just gonna gear back a little bit on the factor of age. Tilo, you're the host here. This is Hamburg. We're very honored to be here today with you. Do you think that age is a sort of like a cutoff, or there isn't a cutoff for age that we should do open arch for somebody, or we should just venture into the endovascular side of things?
You mean for patients or for surgeons?
Patients. I like that.
I think this is clearly a moving target, and I've not been following the discussions for as long as many others here, maybe only for 10 years. But I can remember when a young patient was younger than 70, and today a young patient is sometimes younger than 65 or 60 to be considered for endovascular repair. And I believe we will see a similar development as is seen in TAVI procedures. I mean, age, we're not really talking about age, but about high risk, intermediate risk, low risk patients. Age does not really play the major role here. Also, if we saw a beautiful image of a patient that was successfully treated with open surgery or even a frozen elephant trunk by Malak Shrestha in the last session. And it was astonishing that an 84-year-old can undergo such surgery and drive 200 kilometers afterwards. But I guess he's biologically much younger. And I see patients coming into my office that are 85 or 90 years old, and they row more than 10 kilometers a week. So age is not a good measure in determining what kind of treatment a patient should receive.
Great, thanks, Tilo. Heinz.
But maybe for the surgeons.
Yes, Stephan, go ahead, please.
Just want to add something. Now that we're actually treating younger and younger patients, we have to come up with endovascular procedures that can last, forever. It means that they're going to fail. So if they're going to fail the day you design those endographs, you need to come up with a design that can easily be relined on top or on bottom. So we've completely changed the way we design our endograph. We've moved from 2 to 3 vessel fenestrated endograft to 4 vessel fenestrated endograft with 2 proximal or 3 proximal sealing stents, so that we can easily reline them with a thoracic endograft. And now we have options below to use iliac branch devices too. So I think it's important that we also, if we treat younger patients, that we know that ultimately they might fail, and we need to have an easy way to fix them in the future.
That's a very good point, Stephan. But we're going to touch base on this, linking age to the failure of endovascular approaches and devices, especially the device technology as they proceed. But I'm going to come back to Heinz. Heinz, you heard Malak's talk on frozen elephant trunk. Do you have reservation? Are you open to frozen elephant trunk? What can you tell us from your 1,000 and more cases you've done? Do you think there's a future for them?
Well, we are working on that. We try to make the dimension of this operation smaller, getting faster, and improving on our results, defining the patient who is amenable for it better than in the past. So I think we can reach a goal with an in-hospital mortality between 5 and 8% and a stroke rate of maybe less than 5%, something like that. But, I mean, the endovascular approach is there, and if they are able to produce the same results with much less invasiveness, I mean, they will win. So, of course, there always will stay some patients for us, combined disease. Our case today, I was surprised that Konstantinos did not do double bypass grafting, because this guy has got a 2-vessel disease, but it was a very complex situation. So all those cases, or with additional mitral valve insufficiency, so such patients, I think, will stay forever with the cardiothoracic surgeon. But the trend is there, and the results are so good that this is a good alternative in the future.
Okay, so we need to work together. I'm going to spin the question to Gebrine. Heinz touched base on the valve, reminded me that, valve surgery now is in sort of like a revolution, given your hands and your masterclass approaches, and you put Brussels on the map, and you're joining the North American also. This is all becoming more and more interesting to each one of us. Now, the valve surgery and TAVI or TAVR in the US, they're stepping into different zones, and I'm sure Joe will have also in the hindbrain some comments on this. Marfan population. Some authorities out there, they are even, attempting TAVR or TAVI on this population, where you taught us that in a Marfan we should just be so classical, try and repair the valve, give the patient at a young age the good quality of life and the drive to continue on. What's your opinion on TAVR, TAVI, and Marfans?
I mean, for Marfan patients, the real problem is not the valve, it's the aorta. At first,
Okay.
I mean, what is really threatening the patients is the aorta, not the valve. It recalled me that a month ago I had a patient who had the Marfan syndrome and was operated in another institution. Big aneurysm, light, very mild aortic regurgitation. He had the valve replaced and leaving the root. That's really no sense for that. So I think to treat the Marfan, the first thing is to really treat the aorta. That's the first comment for this. So I don't understand the rationale for TAVR in the setting of Marfan if we leave the aortic root or the aortic wall. The second is more and more patients with Marfan syndrome now are coming to us with nearly normal valve because they have a lot of assessment, of evaluation, and they are coming really very early to us with nearly normal valve. So why sacrifice normal valve and putting biological or mechanical or whatever if you can save this valve? The native tissue is the best one. The best one we have. So if you can ensure to these patients achieve an excellent immediate result, preserving his valve and replacing the aortic root, I think that's the ideal for the patient, mainly for the young patients. So I understand that we can go for TAVR in Marfan patients, in redo patients, some patients who had a root replacement with biological valve or failed aortic valve repair or whatever. I understand that maybe we can go for TAVR if the patient is quite old, but in young patients, I think we should do our maximum to preserve this valve. For valve surgery, for us as a cardiac surgeon, in this era of TAVR and TAVI or all those things, I think maybe we'll, in 10, 15 years, we'll have only two weapons left for us as a cardiac surgeon, aortic valve repair and ROS. Maybe it's not the time to talk for ROS. A ROS operation. In young patients.
That's not a weapon. That's.
So no, I can't. Marfan patients with normal valve, nearly normal valve, should have this valve preserved.
Good stuff, Gebrine. Joe, before you fire, I know you have a comment. Gebrine said, this is, the native tissue is the best tissue. I love this. But is it the durable tissue? We know that some of these patients are going to come back for redos, and then you go down the route of, doing all the fancy schmancy stuff.
Well, I actually think Gebrine's right on. So just examine your experience and your conscience a little bit. How many times in your life have you ever seen a Marfan's patient come in with an abnormal aortic valve without a root aneurysm? Don't think very long. The answer is 0. The Marfan's issue is an aortic issue completely. The happiest Marfan's patient in the world is someone who has plastic from the aortic valve annulus to the bifurcation, because they know they never have to worry about it again. Why is that? Because 93% of natural history Marfan's deaths are from aortic disease. And the average age before we had any surgery was death at 36 years old. So this is very, very significant. So you need to fix the aorta, and as he says, as Gebrine says, the geneticists are all over this. Okay, they are referring patients earlier than we ever thought they would, and they're more aggressive than we are. Okay, they want these aortas out before we even say. It's the only time in my entire life, my entire experience, where I've been driven to operate earlier by the geneticists who kind of really understand these nasty aortas, because they're basically they don't have any strength to them. And I don't really believe in present day concepts regarding endografting with the whole conceptual framework behind an endograft that is going to work in a Marfan's patient. The whole thing is going to have to change from an endovascular standpoint regarding Marfan's and Marfan's-like genetically triggered aortic conditions. So those will be still robustly repaired surgically, and the aortic valve is not the issue.
Okay, so Joe, are you an advocate of prophylactic root surgery in Marfan population?
Well, I'm becoming more and more Yes, the answer is I'm getting more and more aggressive about that, and I have to be honest. As I just said, I'm being pushed a little bit by my geneticists who are referring all these cases at very early time frames. And one of the things that on the genetic side of things regarding genetically triggered aortic conditions that's kind of new is the idea of treating younger patients with GenTAC conditions earlier. This is a stampede at the geneticist level as they learn and we learn more and more.
Gebrine, are you an advocate of the prophylactic route?
Yeah.
You know, the general surgeons, as Joe said, they are ahead of us, the oncosurgeons, I should say. Once they diagnose a BRCA1 gene in your genetic profile, then they go for a radical mastectomy. You know, the gene is there. So would you advocate for Marfan population, a prophylactic root replacement, or?
I mean, prophylactic root replacement with valve preservation, yes. Because, I mean, you should achieve when you are operating any aneurysm or Marfan or whatever, you should achieve at the end of your surgery a perfect result in terms of configuration of the valve inside the prosthesis. And if you are able to achieve this, if you are confident in your technique preserving the valve, yes, I will advocate to go for early replacement. The problem is we should not tolerate we should have a zero tolerance for residual aortic regurgitation in young patients in prophylactic surgery, and mainly the eccentric jet or others. So we should really be perfect. And if you are able, I think we can go for prophylactic repair.
Good stuff. This is a good point. Now I'm going to go back to Heinz. Heinz, Joe, Gebrine are talking about some masterclass skills, you know, preserving the native valve. Not every surgeon, whether in this room or outside listening to this debate, could do actually valve preservation surgery. One, because they don't have the skill. Two, they were not trained to do it. Three, heck, my wife is waiting for me for dinner. I just replace the valve and get out. The future is there, but the spin for us to move to the future is not there. How do you join these things? How do we train? How do you move the block? In vascular surgery, trainees and fellows and whoever is coming next, they are trained to do these things. Where in cardiac surgery, those skills are not transferable. The actual surgeon still needs to learn them. How do you comment on this?
Yeah, you raise an important point. I mean, if you're going to do this on a prophylactic basis, you must have the best results. And this is absolutely impossible for all centers. This means we should overcome our selfishness and accept that there are centers of excellence for this or that indication.
So should we just, concentrate all these patients to center of excellence?
Yeah, if you're going to do it on a prophylactic basis, I think you have to do that.
Okay.
I don't know if it's really prophylactic. It's just a lot earlier than prior guidelines would have suggested, that's all. It's not prophylactic. I mean, now we're doing, for example, any woman who wants to get pregnant who's a Marfan's, we would operate on them if they're Marfan's, we would operate on them at any diameter above 4.0 centimeters. So this is not, but 4.0 centimeters is still a Z-score of 3 or 4.
Yeah.
So it's not totally prophylactic, but it's a lot earlier than it used to be.
Okay, good. Stephan, now back to you. We talked about the future. We talked about issues of moving forward. We talked about how we're gonna transfer the skills to the cardiac surgeons of the new era. What's the future to you? Listening to cardiac surgeons, listening to vascular surgeons. What do you think? What's your recommendation? Let's put it this way.
Well, I agree that we need a specific training. We need aortic surgeons or aortic therapists that are going to be trained in centers doing open and endo, starting from the valve and going all the way to the bifurcation. And then when those trained people will join centers of excellence, then probably they will work and be the experts on a specific topic. And can I go back to the Marfan patient?
Absolutely.
Just 2 seconds, because I think it's a great debate. A couple of years ago, the Italian Society asked me to share my experience with fenestrated branch endograft for Marfan. My first answer was, I don't do fenestrated branch in Marfan. And then we looked at our 500 endothoraco-abdominal repairs, and we found that actually, I can't remember, around 20 were Marfan patients. And if you look back at those cases, most of them had 2 sternotomies, 1 thoracotomy, and actually we got good outcomes because the proximal sealing zone was in a previous open graft, and then the rest of the repair went well. So maybe in the future, those Marfan patients will have a valve-sparing root and arch repair, and then starting from there, we'll have the best proximal landing zone to avoid an open thoracoabdominal repair, which is a major insult. I mean, this is.
Would you advocate this prophylactically?
No.
Valve sparing?
No.
Root,
Well,
arch.
the proximal part probably. The thoracoabdominal part never. Because of the spinal cord ischemia risk, then even with the best effort, we were still in the range of 5%, and 5% in a young patient is just too much.
Okay, Joe, you want to say something? Add on?
No, I think for the non-root portion of the aorta in Marfan's patients, it's all about dissection.
Yeah.
So the aorta is relatively stable unless it dissects. So the key there is just to mitigate dissection risk.
Good stuff.
That's the key concept.
Tilo, you're the host, so I'll leave the last word to you to touch base on the future of cardiovascular, though, not cardiothoracic.
Yes, thank you for that honor. I think we will be surprised of the future. We have been surprised before of the developments of endo techniques and other techniques, and we don't know yet. I think I like to stay curious what it will be look like. We have just started to look over the fence of the other specialties and see what they can offer. For me, this was a really great and new experience to see the open procedure. So I can't really tell, but what I know is we should not be afraid of the future. And I think the people who are see endo techniques and new techniques as a threat, they will lose. But centers that see it as an opportunity to come together, to learn from each other, they will win. And what is also clear is that nobody owns a patient. And we are here to serve the patients, and nobody earns techniques. That's the good news in it. So I think this was probably the last words as the music will take
But
over.
the music is beautiful. It's from the 60s. I enjoyed that. I enjoyed hosting you for this debate.
It's actually from 28. It's Heinz Jakob.
I wasn't aware of that.
Yeah.
But thank you so much for being such sports and joining us for this great debate. You've been with Mo Bashir from Aortic Live Symposium 2017 in Hamburg. Thank you.